And I've shadowed many different physicians who, oftentimes it's 40% of their visits are typing or not even making eye contact with a patient. 30% is navigating EHR prompts, 10% clarifying prior authorization requirements. Presence inevitably becomes a casualty, and burnout steals presence first. And what they are trained to do is when not to do something, or when a patient needs 10 more minutes, or if they just need silence, right? That could be really powerful, more times than a prescription, right? Just being present, being there, being emotionally vulnerable. And when the human in front of them doesn't feel that, right? When they don't feel that they're being listened to or explained things properly, oftentimes that's what creates the distrust. And when things aren't predictable, when we have to reset our own expectations, we see that transpire in the relationship. And I think the patient-physician relationship is the cornerstone of healthcare. Again, when we're adding to the workload and we're creating more metrics, we're inevitably adding to the burnout and adding to a poor experience for the physicians themselves.
Welcome to Inside Home Health. I'm Arvind Sarin, CEO of Copper Digital. And today I have a very special guest, Valerie Choniuk, who serves as a policy forum advisor at the Beryl Institute and sits at the peer review board of the Journal of Patient Experience. She works with over 2,200 primary care physicians across the country on something that I think is most important and often the most overlooked piece of healthcare: the experience, the patient experience, the clinical experience, the caregiver experience. Valerie, welcome. Tell me a little bit about yourself and how you ended up in this role and in this world.
Thank you so much, Arvind. I appreciate the time, and it's an absolute pleasure to be here. I started working in healthcare just with a strong purpose of taking care of my grandmother, which really elevated me to want to make sure that from an administrative perspective that we get healthcare right, because every second, every minute that we're in this podcast together, we're getting older, right? We're patients too, and we're going to be there one day. I started working in the hospitality, and then from there I worked in the hospital setting. From the hospital setting, I started working in home health and nursing homes, and then from there working with medical groups, and then working with National Value-Based Care Organization, working throughout the nation to improve patient experience, patient engagement, physician experience, physician engagement, and try to elevate the experiences so that way we all feel comfortable and we all feel the transparency and we feel that we can be and bring our true selves, because whether we're patients or physicians, I think the experience is very similar, and I'm very passionate about making a difference.
Thank you, Valerie. And Valerie, you said something that I think should be on a billboard in every hospital and every home health agency in America. And you said clinician burnout is the patient experience problem. Not that it affects it, not that it's related, that is the problem. Walk us through that connection for the viewers.
Yeah, absolutely. So very early on in my career, I would tout patients come first. But the more that I was enveloped into healthcare, the more I started working with the administrators and the physicians and the advanced practice professionals, it became very apparent to me that we have to heal our healers. How can we expect them to take care of other human beings and commit themselves to taking care of other people to elevate their lives if we're not doing the same for them? I'm a big proponent that the environment that's created in an office and a hospital, the culture, is all based on how we're individually feeling, which creates the collective. And so going from patients come first to now physicians and clinicians come first is big for me. I think that it's something that most systems avoid, right? Clinician burnout, they think it's an HR issue, or they think it's a resilience issue, or, you have to have yoga at lunch, or we need to have ice cream parties and pizza parties. And that's not it at all, right? Clinician burnout, as you mentioned, is the patient experience problem, because again, healing our healers, knowing what flows through physicians is going to transpire to their customers, to their patients, to their families, their caregivers. And in one organization, when I had analyzed CAPS, Consumer Assessment of Healthcare Providers and Systems survey, alongside of clinician engagement, the data was very compelling, and it was a very strong predictor that when there's low patient trust, right, and we're not able to seamlessly get things done, which may cause friction or even cause complaints or grievances, it was very apparent that it was due to oftentimes the culture and emotional exhaustion You know, physicians didn't train for decades on optimizing ICD-10 codes or CPT2 capture or monitoring RVUs or managing MIPS dashboards. There's so many metrics to be measured, and there's so much clicks and codes and compliance. And I think oftentimes for our physicians, their identity gets reduced to dashboards. Their value is oftentimes quantified in just productivity targets. And I've shadowed many different physicians who, oftentimes it's 40% of their visits are typing or not even making eye contact with a patient. 30% is navigating EHR prompts, 10% clarifying prior authorization requirements. Presence inevitably becomes a casualty, and burnout steals presence first. And what they are trained to do is when not to do something, or when a patient needs 10 more minutes, or if they just need silence, right? That could be really powerful more times than a prescription, right? Just being present, being there, being emotionally vulnerable. And when the human in front of them doesn't feel that, right? When they don't feel that they're being listened to or explained things properly, oftentimes that's what creates the distrust. And when things aren't predictable, when we have to reset our own expectations, I'm very big on the psychology and behavioral based patient experience. We see that transpire in the relationship. And I think the patient physician relationship is the cornerstone of healthcare. So again, when we're adding to the workload and we're creating more metrics, we're inevitably adding to the burnout and adding to a poor experience for the physicians themselves.
Got it. Well, thank you for helping us make that connection. And I think it's great that you bring experience from clinics working with physicians and also home health. I think for us right now at Copper AI, the focus has been to first solve the problem for the clinicians. And I see that firsthand as I talk to the clinicians, as I communicate with them, that it's almost very indicative of the overall outcomes. Like you said, the CAP survey, I think it's correlated. Another point I really liked was you mentioned about the trust between the patient and the physician. And I think that's very similar and it translates to home health. So that way I draw a lot of these parallels between the clinics and the relationship that the patient has with the PCP. I think it's of the similar nature when it's home health, because then you're really not all the time with the PCP, but you're at home, and then that primary care, like clinician, if there's such a thing, is coming home and taking care of you. And that's where, if you establish trust, then there would be better patient outcomes. Because, I mean, think about it. You listen and agree with people that you trust. If you don't trust somebody, then why would you? You said something that was very interesting, and it kind of goes back to a lot of the principles that we already know across various other industries as well. As in, if you have happy employees, of course, you're going to have happy customers, right? I mean, it goes with Starbucks or any of these other companies. If you just take care of your employees, if you empathize with them, if you understand what it's to be like them in their shoes, and ensure that you're creating a good experience for them, then it ultimately helps you with the bottom line, with the top line, with the CAP survey, with the patient experience. And that's super fascinating. Tell me about, if you don't mind, some real world stories of when you have maybe joined a company and then you've seen that, oh wow, you know what, these are some initiatives that need to be taken in order to fix the patient outcomes, but the road to that is through getting access to the clinicians, building that relationship with the clinicians.
Yeah, it's a great question. I would say the first thing I do in the first 90 days of any organization is just taking the step back and looking at all of the moving parts and all of the moving pieces and being conscientious that there's history here. There is things that people will want to change. And oftentimes in rounding, right, and getting people's perceptions and their opinions and how they're feeling, I will ask them if there's one thing that they would like to change, what would it be? And oftentimes it's more than one thing. And then I ask, are you willing to be part of that change? And oftentimes it's no. Right. So I think this goes hand in hand with what you just said, right? It's so obvious to CEOs and administrative leadership and C-suite leadership that people are their most important resource. And again, if you take care of your people, the business takes care of itself. So if we know this anecdotally, and we know that this makes sense and that it's not necessarily about the short-term ROI, but the long-term ROI, how are we going to scale it and do so efficiently and cost effectively, then I'm going to pose it back to you. Why does that get ignored so often, right? Why does that become the bottom of the barrel? Why is it that it is not held to the forefront where we are architecting and intentionally designing experience to impact the caregivers, to impact the patient, to impact the physician, right? We know that it makes sense, but it often falls by the wayside. So in seeing that and pulling all of the pieces together and hearing from all of the different employees and the physicians, and then being able to bring that back through focus groups and bring that back to leadership and say, this is what's going on. This is how it impacts you short term. This is the real long-term impact if we don't start to design this intentionally and get it right. So I think that's some of the most important things is listening and listening at scale in a qualitative fashion, whether it's through responding to a survey or having real-time focus groups to really understand what your internal and external customers are experiencing to be able to drive that needle in a more efficient way forward.
Got it. Got it. Yeah, no, that's an interesting question that you pose for me. Like, hey, why don't people do it? And
Right.
I have thought about it deeply because a lot of times us humans, we do things that are contrary to what goals we want to accomplish. And I feel like there is not a very obvious direct correlation that is all the time staring in your face. It's not like, like immediate effects may not be there. So we oftentimes just get in that coast mode and we're like, oh, things are just going. But then you don't know how much suffering there is for the clinicians. And it is suffering because you can't say no. You're having to go. And this comes from me trying to understand the experience for the clinicians. So we have Kathy Duckett. She has 30 years of experience, and she and I have been on this podcast. And she talks about how nurses spend 40% of their shift on paperwork, like sitting at kitchen tables at 9 p.m. finishing charts. And so you work with thousands of physicians and clinicians as well. When you hear that 92% nurses say their EHR system hurts their job satisfaction, like doesn't help, but hurts. And of course, for the audience, EMR is where all of the documentation goes. And I mean, does that match what you're seeing on the ground? What is the biggest challenge? And I understand everyone wants to be seen and appreciated. And of course, there needs to be this camaraderie and you want to be part of something bigger. That is obviously a given. And again, not discounting the importance of that, but in the real practical terms, I feel like the paperwork is a huge challenge. What are you seeing as you talk to clinicians and physicians? And is it different for both? And tell me your experience, if you wouldn't mind.
Yeah, absolutely. I've had so many personal friends as well as just colleagues at work that have left for that very reason. They're like, this is not what I went to school for. This is not what I signed up for. I'm not here to just push paper. I'm here to help human beings and help them get better. And I think it begs the question, are we protecting and are we preserving that sacred relationship of being human to human? Or is administration protecting the system? And I think we need to start to think about that on a deeper level, because when things start to break down and when things are no longer cost effective, which we're seeing in healthcare right now, it's very widespread. With all the different, policies coming down the pike, how do we protect our business? And going back to basics, I've been saying this for a long time, we have to go back to basics because we're seeing it at the individual level. And then that cumulative individual level is what's creating the systemic issues that are exactly the same between patient and these clinicians, right? They're saying the same things. I have administrative overload. There's too many different channels, too many different logins, too many different things that I need to do at the same time in multitasking. We're all expected to do a lot more with less. It's getting more confusing to navigate. And I hear this from both sides, right? It mirrors each other. It's very, very intriguing because it all comes down to the fact that this is a humane experience that we're trying to create for everybody. And the more we push AI in the wrong way, the more that we push on doing all this technical work, this transactional check the box work, the more we're missing the big picture, the less that we're able to drive any type of performance forward, because we can't see the forest through the trees, right? We're so focused on what do I need to do right now to be successful this quarter? And I think that that's a piece of it, but I think the overall strategy has to always be looking at the full picture and what you're doing, because I think we've all experienced it, right? You get to Q4 and all of a sudden everything's blowing up and everything needs to happen at the same time and it needs to happen now. And when things get overwhelmingly like that in psychology, right, we shut down. You sit down at a restaurant, you got a million choices. You're like, I don't know. tell me what I should eat, right? It's the same thing. And when we're not approaching healthcare from that psychological perspective, yes, you're going to see this burnout and it's going to be rampant. And it is not a product of somebody's individual resilience. It is a product of the system.
Got it. Very interesting. A lot in there. I'd love to try to unpack that with you. So I think the main point you're making is that everyone's got their lives busier. So patients have too much to do and too many things that are required of them to stay healthy and have better outcomes. Same thing, clinicians, not only do they have to take care of the wound and teach the medication management and look at the environment being safe and support the patient with that, but they have so much more in documenting all of that stuff and making the call for pre-authorization or discussing with the physician the condition and the plan, updating the care plan, coordinating that with the back office. I mean, there's just a whole lot of work, at least in home health, I can speak for that, so much work that we almost need to have this pencils down moment and we need to say, okay, everyone just stop. No one, I mean, this is something that we used to do a lot. We're like, okay, everyone's writing and, there's talks going on. We're like, okay, pencils down. So everyone just listen, pay attention. What are we here for? What are we trying to accomplish? And I feel like it's a little bit like that. See, I feel like when I look at any problem or any situation, then it's like, what is the short-term goal and what's the long-term goal? And what are some of the short-term steps and the long-term steps that you have to take? Of course, like in this scenario, these things may not immediately show you those dips or peaks as such in the revenue or in the CAP survey, but then long term, it's going to catch up. I mean, it's going to define who you become as a company, whether you become a very fast growing, scalable company that the community loves, or, if you're going to have that stagnant growth because you just can't figure out what you're doing wrong and you're stuck at, 200-300 census at a home health agency managing that type of patients. And I think it sort of goes back to certain small steps over a long period of time have that compounding effect. And I think these are some of the things that are so important and absolutely need to be done. And what are those things though? Like because see, we talked about, of course, I can sit here as the agency owner and administrator and say that, you know what, I love the clinicians, but that doesn't mean that they don't have to finish the start of care that takes 2 to 3 hours. So like, what are some of those practical steps? And, of course, that's a good segue into technology. And you describe AI in healthcare as a double-edged sword. And I love that framing because most people are either all in AI or just completely terrified. And they're like, oh, no, we're not going to absolutely. I mean, there's no nuance. So tell me, what does that bad edge look like? When does AI actually make things worse from at least a clinician standpoint? And of course, if you can wrap the patient standpoint as well, because we don't want to frustrate the patients as well with AI. And, we don't want to make things harder. And I have a few examples that after that, I'd like to share with you on what we learned through some of this experience of interacting with the patients and the clinicians and the agency owner administrators in the last year.
Yeah, I would say the bad edge, right, of the double-edged sword would be AI that generates notes that require heavy editing. I can tell you right off the bat, physicians are not a fan, right? They want to have autonomy. They want to have trust from their administrators. They want to know that they have good judgment. So I think nudges are okay, but when the notes they're reading it and they're like, this does not add up to the practical real world experience, I think that becomes very frustrating. Having
But isn't
prompts.
it the part of growing pains, right? Like first you get the wrong notes. And I say this again, knowing that of course in healthcare there is cost of error could be deadly as well. You can right, but I think that's why it's such a huge problem. And I feel like for the physicians, this may have still been solved because of course, shortage of physicians and they get paid a lot. So of course their time is very valuable, so there are all these tools like Nuance and many others in the ambient scribe world
Mhm.
that work really well for the hospitals and even the clinics, but only for the physicians. But then when you translate that to the clinicians, then
Mhm.
it becomes a huge challenge. Why? Because the way that the ambient scribe works for the hospitals or for the clinics, it's different because there's a very short window when the doctor is interacting with the patient. However, at home, you're doing a holistic assessment and you're doing a lot of that observation. You don't ask the patient directly, do you have social welfare issues and all of that stuff. You ask in a way that you create that space for the patient to share. There's interaction. So it's very different. And some of the things you don't even ask, you just observe that there's the tub's not been used in many months.
Right.
Um, and that's when you observe, you're like, oh, this patient is not taking care of the hygiene, and maybe that's a challenge. So I lost my train of thought on exactly how I was trying, what
Let's
point I.
unpack that a minute. Let's back up because you have a lot of really good nuggets in there. So you had first mentioned, but isn't that part of the growing pains when it comes to AI and physicians and adoption? And I would say the best way to combat that is include them early in what that product build looks like, right? Don't have somebody else who's not a physician build it and then put it out and say, okay, you have to use this, right? You need feedback. And I think starting and getting them involved and included in the process early helps that engagement. So any type of patient engagement or patient experience work I've done, I always included physicians at ground zero, asking them what their thoughts are, what this should look like, what's practical, because you can have the best strategy on paper, right? If that doesn't play out in the real world, that friction automatically, right, it squashes everything. But if you include them early on in the process, you get their feedback, you get some of the psychological safety going where they can be a little combative, right? I want them to get excited about it. I want them to get a little worked up and tell me this has really frustrated me in the past and this needs to be solved for. And this is how I think we should solve for it. Okay, great. Tell me more. I want to learn from your perspective. And then you take that widely across the organization and you get a good sample size of various different physicians and what they have to say. And then you build from there. So then when you build, if there's something that's nuanced or off or doesn't seem right, now they're a little more forgiving. Oh, Valerie, I didn't think about that. Let's talk
Because
about
we're a
that
part of the
further.
same team.
Right, exactly. So oftentimes we have leaders making decisions without including physicians, and then we wonder why it falls flat and we wonder why they get so frustrated because they're humans too, right? They should be part of that process. So I think that's something that we in healthcare could do a much better job of and making sure that their voices are heard too.
Valerie, this is such an important point, but isn't it common sense? But you're right. Like, I see this as so rampant. Like, some technologists who are really good at their craft would say, you know what? Oh my God, this is easy. Let me go build this. And if you build it, they would come, is the assumption. And obviously, that's that. I mean, I've had instances that I've shared in the earlier episodes of the podcast where a Silicon Valley entrepreneur came on for a keynote and talked about how he's built this AI agent that does follow-ups for the referrals in home health. And everyone's like, referrals come through fax. You don't have to call and follow up. And in fact, you get four for every referral that you can accept. So that's not a problem you're trying to solve. Like,
Right.
that is not a real problem. But anyways, and I think, see, this may seem like common sense, but yes, of course, you got to have whoever the user is, get them a seat on the table so you're
Right.
able to empathize. But I also want to, talk about some of the trade-offs for that, because sometimes we get involved with a customer, and they're very strongly like a healthcare provider, and they have very strong opinion about how some of the flow is going to work. And then as a technology company, like, you're not really going towards developing that product and solving that one problem. You just become this extended dev shop of that provider, where, see, because the hypothesis is that no one knows, including the clinicians, that what's going to work. So the way that in Silicon Valley, we have this fundamental model is like, you just experiment, you just try things out. So you go ahead and collaborate with the clinician, and you're like, okay, well, try this out, and then let them try it out and observe them how they're using it. So I think there is a little bit of that balance that might be needed, that even though you want the clinicians to have a seat on the table, but not everything that they directly tell you can be translated to product feedback. They may say that I'm okay to record everything, or they may say that I'm not okay to do this. And while that needs to be considered, but at certain point, you need to perhaps become one team and say, okay, well, obviously there's a technology limitation on this, and obviously this doesn't work. So, and I think that's something that we ended up doing, which Kathy was actually doing a keynote at the National Alliance. And that's when she spoke about the future of EMR. And the crux of her presentation was, hello, don't just be going off and building this by yourselves, but include the clinicians. So
Right.
I'm very familiar with that point. And that's when, after the presentation, I went to her and I said, would you like to be a clinical advisor with us at Copper AI? And she's like, yeah, that'd be great. I've got some vacation, but yeah. So I
That's
think
great.
important point on this, what have you seen as how to strike that balance in include the providers, the clinicians, but really it's not that they would know exactly what they want?
Well, I think it's everything that you just said, right? As long as you're setting the expectation, letting them know, listen, we're not going to be able to solve for everything today. Like, again, we're humans. We get it. When we're sidelined, that's when we're going to get really annoyed, right? We know AI promises efficiency, but if it's poorly integrated, it's going to amplify that friction with your physicians. And now they're going to have 1 ear in, 1 ear out. They're not really engaged. They don't want to share feedback because they're fearful, or they don't want to share feedback because they think it's going to fall on deaf ears, right? So again, just being able to include them in the process, set and manage those expectations appropriately, and having them feel, even if you invite them and they can't join, right? That still speaks volumes. And I think oftentimes, like you said, it's common sense, but there's so many organizations that miss the boat on that. And they start wildly building and going on sprints and doing all of this stuff. And then they get too far down the path where now it's impossible to include a physician because now there's so much tech things that need to be fixed. And at the end of the day, is automation the goal? I don't think so. I think we need to think deeper about that and know that liberation of presence is the goal, right? How do we get people from not focusing on too much on the future where they're living in that fearful anxiety state? And how do we get them out of focusing on the past, which creates possibly depression, moral injury, right? Get them in the present now. This is where we're at in a consumer-driven healthcare world, and we need to start fixing things. And we want to start that with you because we know how important it is to you. And just hearing that is music to their ears because they have not been included in the process for so long, or they've been sidelined. But you never know. You could have somebody who's a clinician, physician, who has a tech background, right? It might seem like a unicorn, but that could be something they're very interested in, or from a finance perspective, right? We all have different skills, different attributes, different talents, and you never know who you're going to pull in the room. So as long as you create that psychological safety, I think that, again, being able to keep people focused on the present and not necessarily staring at a screen constantly is huge.
Yeah, no, well said. And I have my opinion about how AI needs to be this ultimate personal assistant that takes care of everything, and you just go do your things and everything else that happens. And there's obviously so much buzz in the market, and there seems to be a new model every week that comes out. And I've got my personal assistant that I'm building as well that goes and does things for me. But I don't do that with more sensitive and important information. And of course, for patients, I see that AI still has some ways to go. And that's why it's very important to ensure that kind of going back to the earlier point that you mentioned, be honest with the capabilities that are working. Don't oversell, because there's a lot of fatigue. Like, most home health agencies are sick and tired of hearing about AI can do this, AI can solve this, because when they sign up for pilot, the next thing you know, the agency takes a month or not even shows up and the product doesn't work. And that's
Mhm.
why, if you could just be honest when you're approaching that pilot about what stage it's at, I've seen that that works really well. I want to shift to something you've talked about that I think is one of the most underreported crises in healthcare. So there are 53 million Americans right now serving as unpaid family caregivers. 53 million. And you've said that they're essential, but they're ignored. And you've also said that outcomes depend on them,
Mhm.
but obviously they're rarely measured, because of course we've got this Oasis form that is done by the clinician at the start of care, and
Mhm.
then if it takes longer than 2 months, then you have a resumption of care. But no one ever measures all of the care that the family caregivers are providing, and they're rarely trained, they're rarely supported. I mean, why does healthcare pretend that the family caregivers don't exist? I mean, it just, yeah.
It's so ironic, right? And it goes back to what we were saying, is that we're so focused on the short term. Like, how do we look at that big holistic picture? And again, anecdotally, it is so obvious and apparent to all of us, right? Like, I don't know about you, but if people are in their 30s, 40s, 50s, guess what? You're part of the generation where you're taking care of your kids and you're taking care of your parents, right? And so somebody like me, I don't have an MPI number, right? I'm not specifically generating revenue. I'm not a physician. I'm not showing up on my parents' dashboards for quality, right? And absolutely, I help determine that outcome. If my mom has anxiety and does not want to go out and see a doctor or even have someone come to her home, that's very telling. And who's she going to tell that to? Me, her daughter. And then what am I going to do? Mom, you got to go see the doctor. Mom, you got, right? So not only am I the one advocating and helping her to navigate and coordinate her care, but I'm also the one helping to nudge her to help close those gaps, to help get those healthier outcomes. And I'm speaking from this as just being her daughter. Pretend like I'm not a patient experience professional who knows the system in and out, right? And can help her navigate any issues that she has, but just caregivers in general, right? It makes it really personal. I'm sure you can relate to, anybody listening to this podcast can relate, whether it's your parents, your in-laws, right? You're there interpreting insurance letters, you're navigating the portal, you're clarifying referrals for them, you're helping to be the translator for their insurance, which is so nuanced and confusing. You're their appointment coordinator, you're their medication manager, right? You're their tech support when they need it. I think the system runs on these unpaid caregivers, and strategically, as you mentioned, right, it matters. There's millions of patients and they're relying on their spouse. They're relying on their adult child. They're relying on their family, a friend, a neighbor who could be their primary caregiver. In my work with Medicare Advantage patients, I think it's very clear that patients with strong caregiver support, they have fewer admissions, better adherence, better preventative screening compliance.
Absolutely.
Yet we don't measure the caregiver strain, right? We're measuring the readmissions, we're measuring HEDIS, we're measuring CAPS. We don't measure caregiver exhaustion. Caregiver capacity is crucial, right? And again, to your point earlier, having that holistic perspective and knowing that this is something that's very real and we need to start marketing to them to be able to then help their parent is huge. And outcomes depend on oftentimes that caregiver who also might be the one driving them to an appointment or setting up that home health appointment. And guess what? It goes back to what we discussed earlier. When caregivers are burned out, the patient's outcomes are going to decline. So definitely something that I think the environment that we're currently in could really focus on, because it is definitely part of that secret sauce that we're missing, and being conscientious that everybody that wants to have successful outcomes is going to surround themselves with community and going to surround themselves with a village. So how do we leverage that?
Yeah. And I think this about my own parents as well. My dad's getting older, and at some point, my family will be that caregiver role. And the idea that system just assumes that we'll figure everything out without any training and support or recognition. I mean, that's a systematic failure. Valerie, you've also raised a point that I think the tech community doesn't want to hear really. You've said that digital engagement creates winners and losers, and the technology improves care for some people while completely excluding others, older adults, low income populations, people without, let's say, broadband or access to a phone. As someone who builds technology for healthcare, that really challenges me. How do we make sure that we're not leaving people behind?
It's a great question. I think automatically we know that younger populations respond pretty much immediately, right? Whether good or bad, they're going to respond. I think there's an assumption out there that seniors don't respond to text, which is not true. It depends on how you set it up. So they don't respond to uncontextualized text message, right? So you have to test like behavioral sequencing. So what do I mean by that? When I've done this in the past with older populations or seniors, right, you have to first start with something simple and credible. That's not going to feel like spam, like a mailer. Maybe that's a postcard. Maybe that's a letter. You have the provider branding on it. You use very plain language, right? This isn't zhuzhing it up, marketing, right? It's just really a heads up to let them know that a text is going to follow. So then when they get that text, and they all have smartphones now, they can't ignore it, right? They're not going to be able to not read that text. They're going to hear the ping, they're going to open it up, and then they're going to choose, okay, how do I interact with this? We know seniors are very smart in the sense that, spam, and they don't want anything to be a fraud risk. So that mailer really has to create, as I mentioned earlier, that psychological safety with them. And then you layer in those behavioral based nudges. So you have, from a psychology perspective, authoritative cues, loss aversion, social proof, right? It's really about being able to say, hey, like, this is your PCP, and I know this is your PCP, and you've been unmanaged, and I haven't seen you in a long time, and I really want to see you. What's stopping you? Right? And you could even ask them that via text message. And then it's, press M because you moved, or press P because you found a new PCP, right? It doesn't have to be convoluted. It could be really simple, and you can gain a ton of insights from that. So I would say, going back to your original question, making sure that you're contextualizing it for them. So that way it makes sense for them to respond, and they can leverage their free benefits. Maybe let's just say it's Medicare Advantage, right? With whatever their health plan is, or it's just simply oftentimes educating them on what their benefits are that they can leverage, right? In healthcare, we see it and we say, Arvind hasn't closed his preventative gaps for A, B, and C. Does he even know what he has open right now? Probably not, right? Like, I don't know if every senior knows their preventative screenings that they're supposed to get every year unless they're communicated that. A PCP could even tell them what they need to do, but if they don't think their benefits are going to cover it, and now all of a sudden cost comes into play, or they can't get to the office and they need home health, but they don't know how to leverage that. Again, it goes back to information, education, communication, and doing it in a way that meets them where they're at, and make sure not to exclude them, or for that matter, assume that they'll automatically interact, because they won't. So you'll have to do it from a very behavioral based perspective, obviously looking at all your data, gathering insights from it, and being able to then drive the performance outcome that you're looking for.
That sounds like, of course, responsibility. And of course, I take that seriously, because if we build all these different components of AI, like right now, of course, the core focus is TurboTax for Oasis. I mean, get that level of accuracy with the QA done, with having that Q&A. But if we just build it without considering how patients are going to interact with that, or clinicians are going to interact with that, then of course that's not going to solve the problem. Because it's take AI voice for example. In AI voice would work great for a 45-year-old, managing her mom's care, but I'm not sure how much it'll work for the 80-year-old, because even with my dad, sometimes I have to repeat things. And I mean, so the point is, like, we have to many times have multimodal, or, multi-input, if you will. Like, you can be able to take a picture of your meds, or you can, speak that. And that's why we have all these different channels. Like, of course, AI voice, or you could tap and answer. One thing that I'd love to share with you, which I'm very excited about, and this is a change in the way the care is provided. So, Valerie, think of this. Whenever there's home health visits, let's say there's 2 visits a week, or let's say there's a physical therapy once or twice or thrice a week. I mean, what happens in between those visits? And sometimes there are only a certain number of visits that are possible because you only have that much of authorization, but the patient still needs that monitoring. So, what we're doing is using AI to
Mhm.
make a very friendly phone call to the patient in between the visits. Now, again, we can't bill for that. It's not telehealth. And even if it was, you can't bill for a telehealth visit in home health. However, it still helps you knowing and prevent the rehospitalization. So that one I'm just so excited about, but still the proof is going to be in the pudding. And, when the rubber meets the road, we'll see. Because in the past, I have, when we make those calls, like for patient visit confirmation, I'm like, everyone's holding on and we're like, oh my God, let's hope that AI doesn't hallucinate. Or because for older people, the sensitivity level of the communication and, the repetition and the patience that's needed, I mean, it's very different. And a lot of good companies have done, a lot of innovative work. But then again, there are so many different interactions. There's prescriptions and tests and status, and there's home health, of course, being a separate beast.
But what you just said, that white space in between, that oftentimes is not being prioritized, is often not being focused on, and that's
Because
where
it
the
wasn't even possible. Earlier, it
right,
wasn't possible. Yeah.
100%. But it's reminiscent of, like, it makes me think of like my kids going to school, right? They could have the best teacher in the world. If they're not doing well, that falls on me because the majority of the time they're home with me and my husband learning, right? So if we're not, again, conscientious of that holistic experience, we're going to miss out. And just like you said, right? Oftentimes it's going to fall on the caregiver, right? It goes back to everything that we just discussed. And how do we look at that white space and say, okay, what is something creative? What is something different that I can do? And just simply having that touch point for them is huge. There's a new study out, I think, about loneliness and isolation and how that makes seniors sicker than smoking cigarettes their whole life, right? Like, there is something about the human connection and compassion and engagement that drives healing. There's so much that goes into the art and science of it, but the fact that you and your team are simply providing reassurance is tremendous because it's not the technology that fails the senior. It's the poor sequencing of it. It's the lack thereof, right? The not engaging with them through it. Trust is that gateway to adoption for anything. And if you're just reaching out, how many times have I seen in a patient experience survey, I can't believe Dr. Smith followed up with me, 2 weeks later just to see how I was. Back to basics, right? Something so simple. So even if it is technologically driven, right, it's still a touch point. It's still meaningful. And that's the gateway for adoption. And that's going to be the gateway to have them continuing to engage and interact with you. Because at the end of the day, it's all about that stickiness, right, with their provider. It's all about creating that relationship and all about creating that trust and being able to do so in a way that creates that lifetime value of the patient, right? I think it's like now 1.8 million. It used to be 1.4 million for the lifetime value. So yes, of course, healthcare has become a business, and yes, finance is always going to be involved. And we have to think about the revenue generation. We have to think about the margin, and we have to think about that in a humane, creative way, because consumers are not just comparing, home health to now going in the office. They're comparing all of healthcare to everything. Amazon, right? How are you going to make things simpler for me? And how are you going to engage me in a way that makes me want to reciprocate back? So I love that you're doing that. That's fabulous.
And all of that while being cost effective as well, right? Like you
Right.
said, we're not
Texts are
getting
very
extra.
cost effective. They're like pennies on the dollar, right? It doesn't take a lot. You could scale it very quickly. And then if need be, right, connect them to a human. But again, it's just the
Totally.
gateway. It's the first
But I
step.
think the initial innovation and the research, I mean, we've done tens of thousands of calls now. Still, there's something new, a new scenario, because our world is very complicated. So I think all of that time and resources and innovation. And then later on, of course, the inference cost is there as well. I mean, it does cost something to still run and monitor and then have, but then again, I think long term it's going to pay for itself, and many folds. Last question, Valerie. So you've spent 20 years working across hospitals, home health, managed care, clinician practices. If you could change one thing about how we think about experience in healthcare, patient experience, clinician experience, caregiver experience, what would it be?
I would say that for the majority of patients, they are non-clinical. They don't have the expertise. They don't have the education. They could not possibly evaluate a physician if medically the medical care they're providing is right or wrong, unless they get a second opinion or if they themselves are clinicians. So the one takeaway that I would say is that experience is truly the differentiator, because of the sheer fact that the things that, again, the majority of patients who are non-clinical can evaluate you on are those humane aspects of care. Are you listening carefully, showing respect, spending time? Do you know the specialists that I've seen? Do you know the best way for me to navigate my care with you? Are you going to feel comfortable sharing that with me? All of those things make experience the differentiator, because you see this too. If patients like you, they're less likely to sue you. You've seen surgeries where they've left clamps in people's bodies and they're like, oh, but I love Dr. Smith. It's okay. I'll go back in and he'll take it out. What? Like, being so conscientious that compassion is what is healing, and those relationships is truly what is healing. And if we're able to even bring that into somebody's home, right, where they feel they're safest, and they bring that person in to that safety, it then just creates the environment for healing. And if that's truly what an organization is after, healing and getting those better outcomes, you can never go wrong. But if you're too busy chasing the transactions, if you're too busy just trying to get another dollar before your earnings call, right? Like, that's not part of the long-term strategy. And so when things start to get tight, when you start to feel the pressure in your chest, right? That's the time that you need to take a step back and say, okay, it is 2026. This is a consumer-driven healthcare world, whether you like it or not. And I'm not saying that medical care isn't important. It's incredibly important. But what I am saying is, if you don't build that relationship, that partnership, that collaboration, that engagement, that foundation from the beginning, good luck. Nothing else is going to work. So that has to be part of the strategy. And then the other last thing that I'll say, as we mentioned earlier, is that we have to heal our healers. We have to be able to go back and do the work for the people that make the system, for the people that are making it happen every single day.
Heal our healers. I love that. And I think that's the thread that connects everything we talked about today. Clinician burnout isn't separate from patient experience. Caregiver burden isn't separate from outcomes. Technology isn't neutral. It either helps or it hurts. And the only way to get it right is to listen to the people actually living it. The nurses, the patients, the families, the leaders like yourself, Valerie, who are brave enough to say what's broken. Valerie, thank you so much for being here. This was one of the most important conversations I've had in this series. Over to you.
My pleasure, Arvind. Thank you so much for having me. Yeah, at the end of the day, right, if we design technology to protect presence, we'll be in good shape, because when humanity erodes, no dashboard's going to bring it back.
Totally. Yeah. And if you're watching this and you're a clinician who feels burned out, I want you to know that we see you. If you're a family caregiver doing this work with no recognition, we see you too. And if you're building technology for healthcare, build it for the people who need it most, not just the people who are easiest to reach. Thank you. Until next time, goodbye.
Thank you.